Hello, everyone. Can you hear me? Dr. Marwa, Dr. Shihab, and Dr. Azim. How are you, everyone? I hope that you can hear me. And please, if you can hear me, would you confirm that in the chat box, please? Hello? Okay, great. I just need to restart my browser. So everyone else can listen to me. Okay, Dr. Ibrahim. Dr. Ahmed, we didn't start a long ago. Okay, perfect. So we may continue, please. As I told you, the important things or the important procedures for management of retinal detachment are scleral buckling, especially for rheumatogenic retinal detachment, horse planar vitrectomy, and pneumatic retinopexy. Laser barricade followed by observation is the less frequently performed procedures. And we have something from the past, like what's called link of crisis peribulbar balloon. During 1980s, Linkov introduced a peribulbar balloon, which caused which caused which was considered as a substitute for permanent scleral buckling. These balloons are not permanent; they are temporary, but they didn't get much popularity during the 1980s, and surgeons lost interest in such peripalpal balloons for advent of regular scleral buckling and later on for pars plana vitrectomy. What's new today is deniofisol. Deniofisol is an inhalation drug which was used for cystic fibrosis, cases with cystic fibrosis. And they found that it stimulates certain receptors in the retinal pigment epithelium in the retina, which works on reattaching the detached retina. Deniofisol was underwent experimentation in animals and was somehow successful, but some of the drawbacks of deniofisol, this is drugs, this is like Avastin, like Lucentis, it has to be injected intravitreally, cannot be taken orally, and imagine this is one of the drawbacks. You, no one can imagine when some time comes and you can treat retinal detachment by prescribing pills. So deniofisol has to be injected intravitreally, and number two, it has to be injected in a very high dose so that it can stimulate the retinal pigment epithelium cells to reattach the detached retina. And in fact, experiments on deniofisol in retinal detachment are held nowadays. They did not continue these experiments, and in fact, I do not know why, but I guess they will continue someday. It's a good commercial business like Avastin and Lucentis. There will be certain indication for retinal detachment, retinotogenous retinal detachment. Because imagine that these cases with retinotogenous retinal detachment are not necessarily those high myopic patients who have spontaneous RD. There are the cases of trauma, the cases of ruptured growth, who have retinal tear and subsequent retinal detachment. All these patients need treatment. And in fact, some of them, imagine a patient who underwent a ruptured robe repair for a corneal wound or a limbal wound, and on scanning him by B scanning, it was found that he had retinal detachment. So how will you choose to treat this patient? Will you perform scleral buckling on him? And when? Will you perform on table under the same procedure or the next day or in 1 week? Usually for these cases, we wait from 1 week to 2 weeks to perform scleral buckling. But for institutes with pars plana vitrectomy available, we can perform it on table in the same primary procedure as primary repair. And imagine that trauma cases may have intraocular foreign body. And these cases with intraocular foreign body plus RD, recontusionous RD, will make more benefits from pars plana vitrectomy, not from scleral buckling. So the goal of RD surgery. The first, the first goal of RD surgery is treatment of all breaks, to treat all the breaks. And here I want to tell you something. Usually cases with retinal detachment will have more than one break. Bear this piece of information in mind. Don't be happy when you find the first break. That's not enough. Usually, more than 80% will have more than one break. Number two is relief of vitreous traction. If this is the eyeball, and then the vitreous is pulling on the retina, you have to relieve this traction either by circular procedure, applying a scleral buckle in the form of tire circumferentially to indent the whole globe of the eye so that you relieve this traction, or perform pars plana vitrectomy. During pars plana vitrectomy, we will be performing shaving of the vitreous and shaving of the vitreous base and induction of vitreous detachment, posterior vitreous detachment if it's not detached, so that you relieve all the vitreous traction forces. And this was a debate at some of time when some inexperienced anterior segment surgeons had dropped the nucleus, dropped a quarter of a nucleus, for example, and then they want just shift to core vitrectomy and uh, just uh, get this quadrant out of the eye and leave the posterior vitreous face intact and leave the vitreous base, and that's it. Of course, this I consider this a crime. These patients most likely will develop proliferative vitreoretinopathy, will develop retinal detachment and pre-retinal membranes. It's very dangerous, especially if you substitute what you vitrectomized from the eye with silicone oil. Okay, so relief of vitreous traction in pars plana vitrectomy, I consider it to be much more complicated than relief of the vitreous traction in scleral buckling. You have to do good shaving. Radical vitrectomy is not enough. And this was a debate in some point of time when even in diabetic cases, they were comparing radical vitrectomy versus core vitrectomy. Okay, they were comparing this. Is it getting the same result? And of course, no. Of course, no. You have to perform radical vitrectomy and relieve all the vitreous traction. No any more bends because you are favoring the tractional component if you leave any posterior vitreous behind. And these are the causes of early failure. If you don't treat all the breaks, as I told you, remember, in 80% of cases there will be more than one break, and if there is no relief of vitreous traction, either in scleral buckling by choosing the wrong buckle, or in parsoplana vitrectomy by performing core vitrectomy, or not thoroughly shaving the base of the vitreous and removing the posterior vitreous membrane. While the cause of late failure is proliferative vitreoretinopathy. And this is a question. Can proliferative vitreoretinopathy take place after scleral buckling? Can you please make this lecture more interactive? Does anyone have an idea about the answer? Can yes, what are you familiar with the mechanism? Yes, because of cryotherapy, and this is what we will be talking about in few slides. When you perform treatment over the bare area of the retinal pigment epithelium, most likely you'll cause dispersion of the retinal pigment epithelium cells. And this way, you will cause proliferative vitreoretinopathy to take place. And this is a situation and scenario that you don't like it to take place. Scleral buckling as a lost art is not suitable for all cases of rhegmatogenous RP because you may have technically difficult scleral buckling situations. You may have a posterior break that you cannot suture a buckle on the sclera, or you may have a giant retinal tear, or you may have a thin sclera from several procedures done before. For example, this patient had undergone several strabismus surgeries. So he has thin sclera, or he has trauma with ectasia of the sclera. This is very hazardous procedure to perform scleral buckling. And for posterior breaks, you cannot reach after beyond the equator in an efficient way. For such posterior breaks, performing parsoplana vitrectomy and substituting the vitreous with air is more beneficial procedure. However, If this is the eye, this is a cornea, and sorry for the red drawings, and you want to buckle the retina for the macula for neurosensory detachment, for example. We had scleral buckle, which has an arm that reaches behind the globe and can indent the macula, and it's just sutured anteriorly because you cannot take very posterior sutures. But again, this is not a very popular method of tamponading or buckling the posterior sclera. So these technical difficulties and these situations are not the perfect conditions to perform scleral buckling on. Posterior breaks, giant retinal tears, and thin sclera. What are the predictors of primary anatomical success? We have a famous study called SPR study. It has so many phases. It reached around 7 phases so far. And according to this study, the factors that are common among patients undergoing scleral buckling or PPV are the number of the breaks and the size of the breaks. That's why giant retinal tears is not a good candidate for scleral buckling. And these are the most important predictors of primary anatomical success. Not the high myopia, not the aphakic, pseudophakic state, no any other portion, but number of the breaks and size of the breaks. The same study showed other factors to consider: the lens status, size and location of the breaks, the patient compliance, and individual preference. Because substituting the vitreous with gas, for example, will ban this patient from air flights. Of course, everyone is banned nowadays, but this is a different scenario. And the size and location of breaks, this is very important because the patient will have to adopt a certain post-operative position for a long period of time. Scleral buckling is usually employed for primary phakic rhegmatogenous retina detachment, with the exception of giant retinal tear. While pars plana vitrectomy was employed for pseudophakic rhegmatogenous retinal detachment. Can anyone tell me why? Why was this discrimination? Because substituting the vitreous with oil, silicone oil, increases the chance of developing cataract. And in fact, nowadays, recent evidence suggests that pars plana vitrectomy is useful also in phakic eyes. Is useful also in phakic rhegmatogenous retinal detachment. And Steve Charles, for example, said that he doesn't believe anymore that silicone oil leads to leads to cataract development. He says it may cause accelerated nuclear sclerosis, but not cataract, not visually significant cataract. So the debate continues. Choosing between pars plana vitrectomy and scleral buckling is still difficult. Now we'll be discussing techniques of scleral buckling. Just to announce from the start, this is not intended to be an instructional course. We are not giving instructions on how to perform the procedure, but we are elucidating certain points which many of us have forgotten. We are making clear many points that we are not paying any attention to in our exams, in our practice. In discussion with colleagues, we are neglecting all of this. So here we have the term buckling, to buckle. To buckle is a verb. It's a term that means to indent. Literally, it means to indent this piece, for example, whatever this piece was, to exert force so that we indent this portion. So scleral buckling means indenting the sclera. We have a detached retina, so we want to indent the sclera so that the retinal pigment epithelium can touch the detached retina and then keep it attached again. After buckling the sclera and to keep the retina attached, we treat the break through what we call retinopexy. Retinopexy. And this is what we will come to in the next slides. So we have to discriminate between the old technique and the most recent technique. The old technique employed what was called scleral implants. However, recently we are using what's called explants. We have too many materials to use for scleral buckles, but how to fix this buckle to the sclera was either by implantation or explantation. Implantation means to construct what seems to be a scleral pocket and then insert this scleral buckle and suture the pocket and suture the buckle in place. This is the old technique. And of course, this had many technical difficulties, including the thinner scales in some persons, high myopes who are more prone to develop rheumatogenic RD, and trauma patients and patients who underwent several strabismus surgeries. But we had to implant the scleral buckle. We had to perform this pocket. Why? Dr. Marwa, are you familiar with why we needed to perform scleral dissection before inserting our scleral implant? This is because before cryotherapy, we used what was called diathermy. And diathermy better was better applied not on the surface of the sclera, but performing scleral pocket and applying the diathermy from inside. Because diathermy caused scleritis, caused shrinkage of the sclera, so we had to apply it not on the surface of the sclera. However, we are not employing diathermy anymore. We shifted to cryotherapy or photocoagulation by laser or diode laser. So we are using explants. Now we are using explants. The material from which scleral explants are manufactured nowadays are silicone, either solid silicone or silicone cells with air inside. However, this is not the material is not the big issue. The big issue is we have encircling bands and we have local explants. We have encircling bands like here, like A, B, and C. These are called tires, either symmetric or asymmetric. Or we have parts of these tires. These tires are used for circulation. They are used to apply this tire all through the periphery of the globe. Or we need just a local implant, like all the other letters until J, just to implant a certain point of the retina. And you may apply these local implants either locally or diagonally or radially. To perform scleral buckling as a state-of-art procedure, you have to perform a good preoperative assessment, including retinal drawing. And retinal drawing itself is one of the lost arts in ophthalmology. Preoperative assessment, you have first to know, do you remember the first slide? The different types of retinal detachments? We have to make sure that this case is a retinotogenous RD, because these are the suitable cases for scleral buckling. Any features suggestive of non-rigmatogenous RD has to be well considered. Any features suggestive of combined pathology has to be well considered. Just like, I'll go back to slide number 2. Just like this one, just like this picture. Any feature suggestive of tractional component has to be considered. Don't just shift to scleral buckling to show that you are the best surgeon ever. No, just have a good preoperative look and accurate preoperative diagnosis. You have to determine will ocular comorbidity affecting visual outcome. As you know, retina patients, we're not expecting to correct the vision to 20/20 post-operative. However, you have to make sure that this major surgery will change their daily routine. As we are not performing phaco-IOL and cataract extraction until the patient's daily life or daily activities are affected, such major operations like retina surgeries has to have an impact on the patient's daily life and daily activities. If a patient improves from hand movement to counting finger 1 meter, this is a big difference. The patient will be able to help himself with going to the toilet, for example. So don't underestimate this result, but make sure that you obtain at least this result. So consider the case of the macula, any macular involvement. Consider if this patient is glaucomatous. Measure his intraocular pressure, because cases of glaucoma, he will need anti-glaucoma medications. Pay attention to filling the vitreous with aerols or saline after drainage of the subretinal fluid. Don't leave the patient on the high IOP side because he's already glaucomatous. Number 3, always consider the history of strabismus surgery, and this has 2 points to deal with. The first one is that makes the sclera thinner and will make exposure of the extraocular muscles harder. And number 2, strabismus surgery patients undergoing scleral buckling are more prone to develop misalignment of the globe after buckling the sclera. And at the end, localization of all retinal breaks, And this is very important because, as we said, missed retinal breaks are one of the causes of early failure. Careful documentation by retinal drawing chart. And this is an example of a retinal drawing chart. Retinal drawing itself is one of the lost arts in ophthalmology also. No one is drawing the retina. No one is drawing the cornea. We have corneal drawing also on corneal drawing chart. No one is doing that anymore. This may be because we are having better photo documentation of cases now. However, you have to take at least a glimpse on how to draw the retina. As you can see, the attached retina is colored in pink. Detached retina is colored in blue, and this means that blue means fluid, as if there was a fluid in this area elevating the retina. And this is the line between the detached and the attached retina. Lattice is drawn as crisscross lines, and blood vessels are drawn in red. The tears are blue in border and red in the center. Okay, this is the break of the tear, but it's not very evident. The evident here is the pigment, and here is the tear also. And I tell you, there is a tear here, and there is a tear here. Okay, that's why I'm telling you, in cases with RD, 80% has more than one break, even if in the area the attached retina. Okay, so keep searching for the second break even in the attached retina. And in fact, when you draw the retina, you're making big use of this art because this tear, you saw it on the slit lamp by slit lamp by microscopy or by indirect ophthalmoscopy, for example. But intraoperatively, you could not detect it. You just know it's at 2 o'clock, but you could not detect it intraoperatively. So don't go for cryotherapy blindly. This is one of the causes of PVR. But shift to your retinal drawing and see its relation to the bifurcation of blood vessels. We usually draw the blood vessels, the retinal blood vessels, in 7 bifurcations. So this is 1, 2, 3, 4. This is after the fourth bifurcation of the superior-temporal retinal branch, for example. And the fourth bifurcation is usually the clinically evident bifurcation. Or draw a pigmentation. You say that this tear is very near to this area of pigmentation. So if you see the pigmentation, it will be easier for you to detect the tear or detect the lattice and detect the tear. So this is an art that has to be revived, and you have to consider it well, especially if you are performing retinal surgeries. Of course, here we have to consider Lenkoff's rule. You cannot perform a thoroughly examine 360 degrees of the retina to find a tear or a hole. So Mr. Lenkoff shared a rule to follow in these cases so that you may detect where a break is. So we may just uh, consider it lightly now. If you have an inferior detachment, which is higher on one side, so the tear or the hole is usually inferiorly and slightly shifted towards the higher side. You'll find it here in this area. And if it's an inferior detachment with both sides equal, the hole or the tear is exactly at 6 o'clock. Okay? Second part of the rule, if you have a subtotal detachment, the tear is on the higher side of the detachment. If you have a superior detachment, the tear is superiorly at 12 o'clock. And if it has a lower arm, the tail is shifted towards the area of the lower. In bullous RD, and you have small upper arm, the tail is usually in this small upper arm. So you have to follow Lenkoff's rule. And Lenkoff's rule was correct in 90 to 95% of cases. And the remaining 5 or 10% were due to the presence of a second break. And as I told you, this is a very essential point. In cases with RRD, rheumatogenic retinal detachment, there is no one tear. It's more than one tear. For cases undergoing scleral buckling, we are performing anesthesia, local or general. Of course, most surgeons prefer general anesthesia. However, if you are performing local anesthesia, it's still possible. Peribulbar or subtenon, and I prefer subtenon because it will anesthetizes all the extraocular muscles. For the head positioning, in phacoemulsification, usually you are not encouraging the patient to extend his neck. You are telling him to put his chin, his chest. This is a better approach. But in scleral buckling, we are slightly extending the neck to get better exposure of the globe. And this is problematic in patients with neck problems because they will be kept in such position for a long time, enough to make them ache. Of course, you will prepare the patient, drape him, and lateral consultomy, if necessary, will be performed. If the globe is very narrow, if it's sunken globe, and you need better exposure, we will perform lateral consultomy. And this will have a little effect on the procedure itself, except for peritoneum. And I'll tell you how it will affect peritoneum. If you are performing the conjunctival opening, you can perform it exactly at the limbus as if you were shaving the limbus, or you may leave a small frill on the limbus and open it 1 millimeter from the limbus, for example, or you can even perform the peritomy 4 to 8 millimeters posterior to the limbus. In fact, I find this approach, 4 to 8 millimeters to the limbus, it's a very far place to perform peritomy. I guess you can just leave a small frill of conjunctiva over the limbus so that you may manipulate your incision, so that you may reach to the subtenon space, because the scleral buckling is performed in the subtenon space. You want to enter this space clearly and be exactly on the sclera. And separation of the conjunctiva and tenon capsule exactly at the limbus is very hard. You have to be little far, maybe 1 millimeter or 2 millimeters far from the limbus. And this frill all will hold to conjunctiva securely post-operative. And you have to take radial relaxation incisions. After circular opening the conjunctiva, you have to open the conjunctiva by two relaxation incisions because manipulations during the scleral buckling procedure is massive manipulation. So you don't want to lacerate the conjunctiva anymore. Usually the position of the relaxation incisions are horizontally, okay? But you cannot take it horizontally if you have performed lateral consultomy. If you have performed lateral consultomy, you have to take it away from the lateral consultomy. Anyone have insight into the cause? Why are lateral cannot doing the relaxation incisions horizontally? Okay, this is to avoid simplifying. To avoid simplifying. And if these patients develop simplifying following scleral buckling surgery, this will be a disaster because the scleral buckle itself will change the geometry of the globe enough and will cause enough restriction of the ocular movement so that the patient will not be happy with it. Add to this simplifying, this will be a disaster. So is it always 360 degrees peritomy? No. You may perform if you are inserting a local buckle without a circulage, for example, in this quadrant only, you may just do the peritomy from here to here, for example, with a relaxation incision to expose this area of the sclera. So the second part is to isolate the rectus muscle. You need, in scleral buckling, you need to act or to operate exactly on the sclera. You cannot be in the subconjunctival space. You have to see the sclera by your eyes. You will dissect 1 to 2 millimeters from the limbus, cut the tenuous capsule, and you'll find it as if it's reflected right here. And you'll see the intermuscular septa, and you'll see the trabecular ligaments around each muscle. You have to divide this so that you will be on the bare, exactly on the bare sclera. And even the sleeve of tenon covering each muscle has to be divided so that you can isolate each rectus, each pure like rectus muscle. This is not a state-of-the-art procedure. Anyone, any beginning resident can isolate a rectus muscle. But 2 tips for the retinal surgeon: isolate the superior from the temporal side and isolate the lateral rectus from the superior side. Why? Why implant a hook to isolate the superior rectus muscle? Enter through the temporal portion, not through the nasal portion. Yes, exactly, Dr. Ibrahim. To avoid the oblique muscles, to avoid the superior oblique tendon in isolating the superior rectus muscle, and the inferior oblique in isolating the lateral rectus muscle. This is a very important point to consider in the isolation of each case. And then we have to isolate each muscle by a 2-0 or 2-0 silk suture. You may pass the needle, of course, the silk suture is a needle with the thread. So how to pass it below the muscle? Pass it with the reversed needle, just reverse the needle and pass it below the muscle. Or we have special hooks with eyelets here that you may thread the needle into it and pull the hook so that the thread will involve the whole muscle. The next point after isolating all the rectus muscles is to localize all the retinal breaks. You have to carefully examine the peripheral retina again, and you have the drawings, the retinal drawings. Perform again, another time, a careful examination of the peripheral retina with indentation. If you didn't perform scleral indentation during indirect ophthalmoscopy, perform it at this step. This is your chance. You won't have another chances to perform scleral indentation. And you have to perform it carefully. And mark on the sclera all the retinal breaks. And this is the most crucial step in the surgery. We have here several and different tools and instrumentation. We have the Shippen's scleral depressor. This is a scleral depressor that we have in our indirect ophthalmoscope in the clinic. We may sterilize it and use it intraoperatively and perform examination of the peripheral retina by scleral indentation or scleral depression through this Shippen's scleral depressor. But we cannot mark the exact site or location of the break through this Shippen's scleral depressor. So we have the Gus scleral marker. This marker has its tip, which is blunt, it's not sharp, and can depress and indent the peripheral retina until you see the break indented and then press through it. When you press on the sclera, the lamellae of the sclera get compressed and lose its water content. So the bluish coloration of the choroid underneath appears through this temporarily thinned area of the sclera. So when you take your dietary, Whitfield, your violet marker, you can mark the site of the break. We have a combination of Chapin's scleral depressor and Gus scleral marker. This is a shocked scleral depressor. From one side, this rocket has Chapin's scleral depressor. With this side, you come up with the and one of the to Shahab. Can you hear me? Okay, perfect. So I guess you listened to this slide about the different types of scale depressor markers. We had, okay, Dr. Walid. So we had the Chapin's scleral depressor, ordinary examination and examination. We had the classical marker for intraoperatively, the depressor and marker, which is a combination of Chapin's and so these are the different types of uh, marking the retinal tears. Just regularly as a state of art, we could use just a regular forceps, either toothed or non-toothed. Even toothed forceps can work. May just indent it with the soft part of the forceps and try to hold this area of the sclera and then mark this part either by diathermy or by your gentian violet marker. Localization of the bricks is an art. It involves retinal drawing, preoperative examination, intraoperative examination, rule of Linkoff, and something very important that's called the parallax effect. It's evident specifically in bullous retinotogenous RD. In these cases, retinal breaks usually are more posteriorly localized than they truly are. I bet you are familiar with the parallactic moment. This is something in the optics, which denotes that something in the middle of your eye and watching target screen will appear in different positions if this object is in different distances between your eye and the watching screen or the watching distant object. Watch this photo carefully. If you are examining the retina and the bullously detached retina with the break or the hole in this area, you will determine by indentation, by indenting the sclera, that the tear is located here at A, at A. While if you drain the subretinal fluid and let the retina shift back to its place, you will find that the tear or the hole truly situated at B, not at A. And this is what's called the parallax effect in localization of the retinal breaks. This means in bullous retinotogenous RD, retinal breaks are more posteriorly localized than they truly are. This is a very important point. So in these cases, we have a protocol for management. We first drain the subretinal fluid. In bullous RD, we first drain the subretinal fluid and inject, yes, exactly, Dr. Marwa, this is base, and then inject fluid or even at some points of time air, which makes the view very bad view, to reconstruct the volume of the vitreous, and then we may localize the retinal break. Now we come to retinopexy. We have localized the break, and we have performed subretinal fluid drainage or not performed it as a part of the procedure. But now we have to fix the retina in place. We have to do pexy. What's pexy? Pexy is a suffix which means fixation, to fix something. So retinopexy means to fix the retina. So how can we fix the retina? The prototype of retinopexy was diathermy. This was employed previously, and we needed to employ it under scleral flaps to dissect through the sclera and perform it on the under scleral flap. And this was the procedure of implanting the scleral buckle and the scleral implants, not the scleral explants. So cryotherapy, this is a widely accepted protocol and the widely accepted procedure performed nowadays. This avoids the drawbacks of diathermy: no more scleritis, no more scleral shrinkage, no more scleral lacerations or cuts. And the third one is laser. And we may perform laser through two ways. Either intraoperative diode laser. This is an external extrascleral probe that we apply on the sclera. And then, if any one of you performed CPC, ciliary body photocoagulation for glaucoma, this is a probe, an extrascleral probe. It's not performed on the retina itself, it's performed over the sclera. So you cannot, one of its drawbacks is that you cannot judge the amount of treatment by seeing the retina from inside. Okay, so this is what you can consider light treatment of the retina. Or the second option is to perform post-operative photocoagulation. Wait 1 or 2 days post-operatively and then take the patient to the argon laser room and perform argon laser photocoagulation. And this, of course, has many drawbacks. It's not immediate effect. You have to wait several days. And even if you do not wait and perform it in the same day, this is a second procedure. It's not done intraoperative. It's done as a second procedure. This is a cryotherapy. This is the model, the main model of performing the retinopexy nowadays. This is a probe of the cryotherapy, and you are indenting the exact site of the tears that you have detected or that you have marked on the sclera. And you start the treatment, and this is a treatment, white ball of ice. And you can see well if the retina is not in direct contact with the RPE. You can see that Doing light treatment may affect only the wall of the eye, and doing heavy treatment may freeze both the RPE and freeze the retina itself. So, on performing cryotherapy, which type do you prefer? To freeze only the RPE or to freeze the RPE and the retina? Dr. Ibrahim guesses both. So, any insight into why? Dr. Marwa the same answer. So, why do you think it's both? Okay, Dr. Shihab has different answer. Well, in fact, both modalities of treatment work. To freeze only the RPE or do heavier treatment to freeze the RPE and the retina, both work. But a histological study of these retinas which underwent freezing and this retina which did not undergo freezing showed that in cases with freezing the RPE only, this induces chorioretinitis and chorioretinal adhesions. But they lack the interdigitations between the RPE and the retina. So the adhesions histologically are not that firm like cases with which underwent freezing of the RPE and the retina combined. Okay? So your guess was right, Dr. Ibrahim, and you have now the histological evidence of your correct answer. This is how you will perform cryotherapy. To do cryotherapy on the edges, starting from the ora serrata posteriorly to circle the tape. And remember, don't don't treat this area. Don't treat the RPE itself. You are dealing with the dry area inside the retina. Don't treat this area. Why? Why shouldn't we apply cryotherapy to the bare choroid or the bare RPE area? Or at least don't apply heavy cryotherapy to this area? Dr. Marwa, you answered this before. Yes, exactly, to avoid PVR. Because treating cryotherapy to this bare RPE area is the main cause of dispersion of the RPE cells. And this is the main cause of developing proliferative vitreoretinopathy. So, need treatment, good treatment in the designated areas is the thing that gives the best results and maintains these best results. Okay? The last thing to consider in this lecture is using the probe. One of the worst scenarios to which beginners in retinal detachment surgery commit is the indentation with the cryoprobe. They insert the cryoprobe in this way, and then it seems that this area that they have marked by the break or the tear is indented, while in fact the tip of the probe is here. And the worst scenario is that it's by the macula. So when they start freezing, in fact, they freeze the macula. This is a nightmare. This is a disaster. So posterior freezing is an important. Shaft indentation is a disaster. They have to avoid it, and they have to get the experience of the appearance of the indentation of the probe, the tip of the probe. These are the most important points in one of the lowest arts in ophthalmology. These were uh, the most important tips and tricks to to pay attention to in scleral buckling surgery. It will keep its place. Scleral buckling will keep its place. Parsoplantar vitrectomy will keep its place, and pneumatic retinopexy will also keep its place. A small take-home message that rhegmatogenous retinal detachment, usually in more than 80 to 86% of cases, has more than one break, even if you find the second break in the area of the attached retina. Retinal drawing is very important. You may detect pigmentation or blood vessels that are near to the break or the tear that will assist you intraoperatively. Combined pathology of the retina, like combined fractional rhegmatogenous retinal detachment or giant retinal tear, are things that need to be considered for parsoplantar vitrectomy. And the last thing is cryotherapy. It's not that easy and not that difficult procedure, but you have to realize how the appearance of the tip indentation appear and avoid the shaft indentation to avoid posterior freezing, and don't treat or over treat the area of bare retinal pigment epithelium. As I told you, this is not an instructional course on scleral buckling. I hope that it was useful and beneficial to you. And in parts 2 and 3, we may speak deeper into the types and the methods of suturing the scleral buckling. Everyone's welcome, and hope to see you soon. Welcome, you're welcome, Dr. Shahab. Thank you, Dr. Ibrahim. And you can always contact us in Moonlight Academy if you want any specific topic to give a presentation on. We will be very grateful to all of you.